So today I'm going to be giving an epidemiological overview of viral hepatitis. I'm not going to say that too many times, but essentially I'm just going to be presenting some of the local data with a specific focus on the region, but also talking about some of the national indicators, how we're progressing in terms of targets and strategies and that sort of thing. So I'd also like to acknowledge our funding from the Australian Government Department of Health and also our other agencies and also my colleagues at the Doherty Institute. So there's already been some information provided about the global context for viral hepatitis, but I'll provide a little bit of detail on that, as well as information about the prevalence and distribution of hepatitis B and C in Australia, both by population and by region, and looking specifically at the local area we're in at the moment. And then talk a little bit about some of the clinical outcomes and the management. We've heard from the team at Liverwell around some of the sort of information about treatment and care, but I'll be talking a little bit about how we're doing, how well those treatments, those amazing treatments that we have are getting into people, and how we're doing in terms of progress in uptake and where the gaps are and where improvements are needed. And I'll be presenting data from the mapping project, so I'll just let you know I've got a few copies of the report. If anyone would like one, you can look up your local area, you can check out all the details, but also just want to encourage people, if you have any feedback or thoughts or experiences you want to share in relation to the data, what you're seeing, whether it's the same, whether it's different, what are some of the causes you're experiencing. We'd really love to hear it, so please jump in either during the presentation or at the end. This has already been discussed, so I won't go into too much detail, but I think it's always important to take that broader picture and really appreciate that viral hepatitis is just an immensely significant global health issue. And when we're talking about viral hepatitis, really in terms of the burden of disease, it's chronic viral hepatitis. And those are chronic hepatitis B and C are the cause of about 90% of the deaths that you can see there. And in terms of the number of people who are affected, there's over 350 million people estimated to be living with chronic Hep B or chronic hepatitis C worldwide. But the key takeaway, I think, really is that hepatitis B and C outcomes, those liver cancer cases, are almost always preventable. We have an effective vaccine for hepatitis B, we have effective treatments for Hep B and C that both reduce the risk of liver cancer. Unfortunately, for many of the other conditions here, we don't have we don't have a vaccine, or we don't have effective treatment. And so, in a way, we really have the tools. The issue is how we get those tools where they need to be. So just a little bit on the progress in terms of hepatitis B vaccine. Again, I think it's always useful to look back at what has been achieved and sort of reflect on that. So globally in 2019, 85% of infants received hepatitis B vaccine, the 2-month, 4-month, 6-month dose, which is really an incredible achievement. And that's been gradually increasing since the vaccine began being used in the 80s. And one study from China found that just from birth dose and infant immunisation, it's estimated that over 30 million cases of Hep B were prevented, which means that over 5 million liver cancer cases and nearly as many deaths were prevented, which is just really amazing to think about. But obviously there are still issues, so gaps still exist in coverage. There's still a gap in infant coverage, but also in birth dose. That coverage is only about 45%, so that's still an issue, particularly for maternal child transmission, and Nafisa will be talking more about that. But then the other issue is, as I mentioned, there's still over 300 million people living with chronic hepatitis B worldwide, and the vaccine doesn't obviously affect them. So for that cohort, it's more about getting access to treatment and care. And in terms of that, we're not really tracking very well, so only 3% of people globally received Hep B treatment, and it's estimated that that proportion needs to be at least 20%. And then for hepatitis C, as we've heard, highly effective low side effect cure is available, and obviously harm reduction practices are really important, and infection prevention as well, particularly in developing countries. So moving into Australia, so at a sort of overview level, hepatitis B, chronic hepatitis B is estimated to affect over 220,000 Australians. That's the figure for 2020. And as has been discussed, the majority of people affected were born overseas, and this chart just shows the distribution of those key populations. Some of them have been touched on already, but you can see in particular those born in the Asia-Pacific region are strongly represented there. And it just gives a sense of the diversity of the population that we're looking at here. It's lots of different sort of community needs and priorities within the community affected by hepatitis B. And because of this, the way that infection is distributed, there's the sort of flow-on effect that this means that infection is distributed differently according to region. And so for hepatitis B, there's a strong geographic clustering in metropolitan regions, and then also in remote regions that have a larger Aboriginal and Torres Strait Islander population. So as you can see on the map, Northern Queensland, Northern Territory and Northern WA. But then also clusters in Melbourne and Sydney, where there are large numbers of people born overseas settled in those areas. And that has impacts obviously for service delivery, making sure that we're tailoring programs that are relevant to the communities that are affected. And again, just to emphasise that the vast majority of people who are in these groups, the people born overseas and Aboriginal and Torres Strait Islander people, almost all acquired their infection at birth. And so if they've migrated to Australia since then, they have hepatitis B now. And so prevalence tends to reflect the country where someone was born. And so this chart presents in a sort of graphical form the data that I mentioned around geographical clustering. So you can see there this is divided by primary health network, and Melbourne, Sydney and sort of remote PHNs are the ones with the highest prevalence. And then you can see I've just highlighted the three Victorian primary health networks which have a much lower prevalence of hepatitis B than average. And this obviously can present a challenge for service delivery if you've got the number of people with Hep B is more distributed across the population, it's less clustered. That can actually be harder sometimes to have services that are tailored because you're seeing a smaller number of people coming through the doors. So that's definitely a challenge, and a lot of regional areas face this same challenge. So just putting this sort of in a map version, so I've just highlighted the Bendigo region there. You can see that, again, the burden of chronic hepatitis B is strongly clustered in the metropolitan Melbourne region, but there are also parts of regional Victoria that have a higher than average proportion of the population living with Hep B. And still, at an overall level, it's estimated that about 6,500 people in the Western Victoria and the Murray primary health networks are living with chronic hepatitis B. And I've just included both of those because obviously Bendigo does sit quite close to the border of the Western Victoria PHN, so there's probably some drawing from that catchment for services in the region. And for most regional areas in Victoria, the proportion of people living with Hep B is it's higher for Aboriginal and Torres Strait Islander people in general in rural areas, but also the predominant countries of birth can be different, and so they're just the top 3 countries of birth for the Murray region. And again, has impacts for tailoring resources, tailoring services, education, information, all that sort of stuff. And for further information about this, we can provide more detailed and more tailored information for specific regions, so feel free to get in touch with that. So moving over to hepatitis C now, so it was estimated in 2020 that Hep C affected 118,000 Australians. That's a really significant drop from how many people were estimated to have Hep C in 2016 due to the impact of treatment and cure, which is really amazing. So now hepatitis B is actually more common than Hep C, which didn't used to be the case. And we've already touched on the priority populations, but I'll just highlight some data that I extracted from Victoria's notifiable diseases database. So these are just some of the key high prevalence countries for hepatitis C that are showing up in terms of notified cases of Hep C for Victoria. So these may be people who are more likely to be recently arrived and recently diagnosed, but does give you a sense of some of the diversity in that population. And you can see from the map, again, there's clustering of hepatitis C incidence in more remote regions of NT and Queensland. But in terms of the rest of the country, there's a much more even distribution of hepatitis C across Australia, and it's not that same clustering in metropolitan regions, just because the sort of drivers of infection and the priority populations are different. And this obviously has impacts for the priorities in those regions. And then again, presenting that in a different way. So this is again ranking all of the primary health networks in Australia from highest to lowest hepatitis C prevalence. And so I've highlighted the 3 regional Victorian PHN. So you can see that Murray is just slightly above average, and Western Victoria is a little bit below average for hepatitis C. But you can see just from where the national average sits that there's a much greater representation of regional primary health networks. And for example, many of the Melbourne areas actually have lower than average prevalence of hepatitis C. And there's sort of impacts on treatment uptake as well that I'll show later. And then again, just drilling into the regional Victoria sort of area. And so in the Murray PHN overall, where Bendigo sits, the hepatitis C prevalence is above average, but that's largely concentrated in the sort of border regions, so Mildura, Swan Hill and Shepparton. You can sort of see those darker green areas on the map. And Bendigo is more similar to the state average in terms of prevalence. But just for a comparison, so the Murray PHN has roughly twice as high prevalence as the Eastern Melbourne PHN. So some of the regional areas do have a much greater burden as per head of population of Hep C. It's important, I think, not to just focus on numbers of people living with Hep B and Hep C. It's always important to reflect on what are the outcomes, what are we really talking about when we're trying to identify priority populations. We're really talking about incidence of adverse outcomes, including liver cancer. And this just really highlights what a priority liver cancer needs to be in our response. These are data from the Australian Institute of Health and Welfare, and they've found that liver cancer is by far the fastest increasing cause of cancer death. It's increased by over 200% in incidence in the last 30 years. And the most common causes shown in Victoria through hospital cohort studies, hepatitis C, alcohol and hepatitis B, responsible for about 75% of all liver cancer. So this really needs to be the priority. And then as part of the mapping report, we also track liver cancer incidence according to region, and so you can see here that that reflects those areas of higher prevalence for particularly hepatitis B by PHN. So you can really see that very strong connection between having a lot of hepatitis B incidence and a lot of liver cancer. And these data are to the end of 2014, so we're hoping that as we start to progress further in providing care and treatment, that these numbers will start to shift. So just to reinforce what's been talked about the high efficacy of hepatitis B and hepatitis C treatments, so there's already population level data that demonstrate that these treatments have already been having an effect, which is really great to see. So these are modelled data but based on real-world inputs. So you can see from the time when highly effective antiviral treatments for hepatitis B were introduced and put on the PBS, after a bit of lag because there's time for them to take effect, you can see a clear decline in the number of people who were dying of hepatitis B, and that's in contrast to what was previously an increasing trend. So we've actually managed to reverse that trend, and that's with treatment uptake not where it needs to be. So that's really good to see and really provides a bit of an insight into what we could achieve if we increase treatment uptake, because as you can see it's sort of plateaued there because we haven't been increasing uptake any further. I'll talk a bit more about that later on. And then for hepatitis C, the impact is even more stark. So these are linked data from New South Wales, but the pattern is very much similar in Victoria. So there was a very clear and worrying increasing trend in the number of people who were developing decompensated cirrhosis, advanced liver disease, due to hepatitis C. And then once DAAs became available, this highlights when they became available through clinical trials and early access programs, there was an immediate decline in the number of people who were developing advanced liver disease, and this is only in the first 2 years of access. It's estimated that between 2016 and 2020, the number of people who have died due to decompensated cirrhosis has decreased by about 45%, which is just amazing to see, and I think should be really celebrated as an achievement. As for Australia, in comparison globally, we've really made a huge impact. But again, the numbers are there's still significant numbers of people who are unfortunately experiencing these adverse outcomes, and there's still room to improve in terms of treatment uptake. So I'm going to talk a little bit about that now. I'll just pause before I go into the measures of uptake and check if anyone had any questions about the data so far on prevalence or any of that. Cool, great. So this is the chart that really explains the previous chart. This is the number of people treated for hepatitis C over time, and you can see the absolutely huge uptake once DAAs were listed on the PBS in 2016. That sort of pace probably couldn't have been continued indefinitely, but we have seen a decline over time in the number of people receiving treatment each year, and that's been relatively stable each year. So that's something that if it continues to be at this pace, we actually won't be on track to reach our target levels, and there'll be significant numbers of people still experiencing adverse outcomes. I'll talk a bit more about that later as well. This chart just shows those trends over time, but I wanted to highlight here that we still have significant numbers of people who are both not even diagnosed with hepatitis C, they haven't even had an antibody test to confirm that they have been exposed, and then a significant proportion of those, so about a quarter of those people who are hepatitis C antibody positive haven't had a PCR test, and Pearl talked about this and the importance of that, not only for making sure that people who have chronic infection can access treatment, but also so that people who don't have chronic infection can know their true status. I think that's a really important component of it. But as you can see, again, the number of people living with Hep C is declining each year because of the impacts of treatment as well. And so, as you might expect, the pace of that increase and how the trends are moving for hepatitis C treatment has not been equal across different areas, but it's been great to see that regional Victoria has definitely been overachieving when it comes to hepatitis C treatment uptake, and so all the regional PHNs and in fact, all of the Victorian PHNs have treatment uptake above the Victorian average, above the national average. And Western Victoria and Gippsland are actually first and second ranked when it comes to treatment uptake. And Western Victoria is actually the only PHN that's already met the 65% treatment target, which is really amazing to see, and I think speaks to the really great work that's been done by so many people working in the region. Just showing that on the map, you can see here there's a little bit of variation in terms of treatment uptake for hepatitis C, but sort of Bendigo and some of the surrounding regions have higher than average treatment uptake. So sort of Heathcote area and around Daylesford both have higher uptake than average. But generally, Victoria is doing quite well when it comes to hepatitis C treatment. And as I mentioned, there's a lot of people doing really great work, but it's not just about that. There's all of these other factors that influence treatment access, not just for Hep C, but for every health condition. And some of the factors that are associated with lower Hep C treatment uptake are essentially the factors that are associated with lower health service access in general, and sort of talk to some of the broader issues around systemic discrimination. And so people who have regions with a lower average socioeconomic status, regions with a larger proportional Aboriginal and Torres Strait Islander population, and then linked in with that, regions that are more remote and have more limited health service access, and those regions with a high burden of Hep C are less likely to have achieved high treatment uptake for Hep C. And these are not surprising, they're things we see for all health conditions, and they require a much bigger sort of solution than just a single disease, but just to highlight some of the factors that are relevant here. So moving on to hepatitis B. So unfortunately, the picture of progress for hepatitis B isn't nearly as positive as it is for hepatitis C. We have made quite a bit of progress, but there's still really significant gaps. And as you saw from that chart, still leading to significant numbers of deaths due to untreated hepatitis B and unmanaged hepatitis B. So you can see from this diagram that about a quarter of people living with Hep B are undiagnosed, and the vast majority are not engaged in regular care. So we heard about the importance of people getting regular viral load tests, getting liver function tests, those sorts of things. So in 2020, only about 23% of people actually had that, had the test that would mean that they could get that sort of regular care. And so that's by far the largest gap in the cascade of care for hepatitis B, and where we really need to focus in terms of re-engaging people who've been previously diagnosed and trying to get people in for more routine care. And then when it comes to treatment uptake, we have a rough target of about 20% of people at a minimum we think need treatment, because not all people with Hep B need treatment. It depends on the disease stage, but at any given time it's about 20%, and only about half of that is where we're at about 9-10% of people receiving treatment in 2020. And there's been some impacts due to COVID in some of these indicators, which I'll talk about as well. So again, just showing that in terms of distribution by primary health network. So you can see here that essentially higher treatment uptake for hepatitis B is very much clustered around Sydney and Melbourne primary health networks, but also the Northern Territory is quite close to the national average, which is good to see as well. And I've highlighted the Victorian PHNs, the regional PHNs, but as you can see, it's very much most regional areas in Victoria. Most regional areas across Australia have below average treatment uptake. That's just sort of the pattern that we see. And it's important to highlight, I think, it's easy to focus on some of these areas that have lower treatment uptake, but some of these areas have very low populations, very remote regions, and very significant health service access challenges. And it's important to highlight that of all people who are untreated for hepatitis B, half of them live in those Brisbane, Melbourne and Sydney PHNs. And so it's not simply a question of looking at the proportions, we need to be looking at the overall numbers as well, and not to suggest that the burden is entirely on regional areas to improve treatment uptake. All PHNs in Australia need to make progress, and none of them have yet reached the target, and there's still preventable deaths occurring in all of them. So just to give a bit of context to that sort of picture. And again, just showing that on the map, so you can see that Bendigo and then sort of some of the surrounding regions have higher than average treatment uptake compared to the rest of regional Victoria, and also the Swan Hill area is above average as well. So that's good to see, and that's something of a pattern that we see generally across Australia, that regional cities and larger towns have higher treatment uptake. And it's potentially sort of due to some of those service aspects or that sort of thing. But again, I'd be really keen to hear people's experiences and whether this is sort of matching up with what you're seeing in your clinical care or in your communities. So just finally, I wanted to talk a little bit about some of the drivers of the lack of diagnosis, essentially. I showed from those charts that roughly a quarter of people with Hep B and a similar proportion for Hep C are undiagnosed. And this is data from over 430 GP practices across Victoria, and shows the proportion of people who had evidence of testing based on established guideline-based indications for hepatitis B and hepatitis C testing. And so you can see there that overall testing was lower than we would like. Only about 30% of people who had an indication had evidence of testing, and it was particularly low for people who had an ethnicity that suggested that they were at risk of Hep B or Hep C, Hep C more so than Hep B. But also really concerningly, a lot of people who had a diagnosis of liver disease or test results that suggest that they might have liver disease still didn't have evidence of Hep B or Hep C serology testing. That would be really important, obviously, in understanding what's going on with their disease. So I think this highlights just one of the areas where improvements can be made in terms of identifying people and linking them into care. But just to highlight some promising data as well, you can see that for people who have a history of injecting drug use, uptake of screening was quite high, and I think that speaks to the high level of awareness that many healthcare providers have of that as a risk factor for Hep C, and that's good to see because that can be a challenge. And then just lastly touching on the impacts of COVID. So this has been talked a little bit about in terms of screening, but just looking at treatment uptake. So Victoria previously had higher than average treatment uptake for every year through 2016 through to 2019. You can see there it's the sort of grey dashed line. In 2019, it had the highest treatment uptake of any state or territory in Australia. But by 2020, due to the impacts of COVID-19, it was ranked 5th out of 8 states and territories. And so a really significant shift there. Generally, Victoria has had such high treatment that it hasn't really started to impact too much because we had a pretty strong start. But if this trend continues, it could be really concerning. And I just also wanted to mention that the impacts of COVID-19 go well beyond just whether a given health service was open or closed or whether there were distancing regulations. I think we've seen really good evidence that the broader social, psychological and economic impacts of the pandemic have been very wide-ranging, and all of those factors can be playing into maybe why people aren't presenting to healthcare or that sort of thing. So I think we need to take a bigger picture look at it. But yeah, this is relatively concerning, and I don't see any reason why this wouldn't have continued through 2021. So we might have some ground to make up in terms of treatment uptake. And just one other thing to highlight, so the areas with the more substantial declines were those where there was lower uptake of GP prescribing. So GPs are now the most common prescribers of Hep C treatment, about 45%, but in Victoria that's much lower, and in those regions that had lower GP prescribing, there was a greater decline during COVID, and I think it's plausible to me that that could have been due to sort of a lower resilience of health services because so many hospitals were very much overwhelmed during COVID. So yeah, that's one factor that potentially increasing GP prescribing could help to mitigate some of these impacts. And talking about hepatitis B, so the impact on hepatitis B was quite stark. So unfortunately, for the first time ever since we've been tracking this, the proportion of people who were receiving care for hepatitis B actually declined during 2020. So fewer people were receiving regular monitoring than they had been the year before. Treatment uptake didn't decline by nearly as much, and I think it makes sense given that you can prescribe treatment via telehealth, but receiving care requires a blood draw, and that could be an extra barrier for people. But this is really concerning that we've seen this. We're already well behind our targets, and so I think we're going to need to do some additional work to try to improve this even beyond what was needed before. There's my arrow. In terms of how we're tracking, so this just shows you the numbers over time. So you can see, as I highlighted there, the care proportion going down. And as you can see, based on the year we're estimated to reach the targets, we're well off where we should be. The closest we're at is diagnosis, but of course, if people are diagnosed but they're not accessing care, that doesn't really help us much. So some significant change is needed to be able to shift these numbers and make sure that people don't experience adverse outcomes that are totally preventable. When it comes to Hep C, we're doing much better. We're quite close to the targets, but unfortunately, because of the declines that we've seen in the last couple of years, we are now not tracking towards them. So these are the targets that are laid out in the national strategy and then the global strategy. So even under the most sort of optimistic pattern of continued decline, we're not on track. So we need to actually start to level things out or even increase treatment numbers if we're going to get to these levels and have a greater impact in reducing the number of deaths and cases of advanced liver disease. And just to highlight, particularly in the regions for hepatitis C and hepatitis B treatment uptake, the decline in hepatitis B treatment uptake in Murray and Western Victoria was actually much less than the Victorian average, which makes sense given that the impact of COVID was really concentrated in Melbourne. So that's really good to see. But for hepatitis C, it still was a greater decline than the national average. So there seemed to be some impact there. And I'm aware that such a big proportion of hepatitis C treatment occurs in correctional facilities, and I know that has been impacted by COVID as well, so that could be one of the factors there. So just in summary, viral hepatitis is a significant global and local public health issue, but we do have the effective tools for preventing infection and for reducing adverse outcomes, and they've already had a really significant impact. And I think we should sort of take inspiration from what's been able to be achieved, but we still need, we're not on track to meet our targets, and we still need significant changes. And COVID-19 has had a negative impact, but I think also it can potentially have a positive impact. Things like the expansion of telehealth might be able to be something that we carry forward, and hopefully potentially some increased awareness around public health and those sorts of things. There's a possibility for that to become positive now that things are returning to a little bit more of normal, and hopefully we can re-engage people. And we hope that understanding the priority populations and specific gaps can help to better target interventions. If you'd like any more information about our project, you can, as I mentioned, you can grab a copy of the mapping report at the table, or you can visit our online portal and explore all the data. You can sort of select different areas, and please feel free to email me if you have any queries or specific requests. Thank you so much. I'm happy to take any questions.